I'm here with Professor Dave Singh. And any of you who have an interest in sleep, well, this is going to be a conversation not to miss. We are going to bring together scientific elements, but also make it user friendly so that anybody who's listening is going to get something out of it. And it's a fascinating subject, really, really is. And it's a subject that affects absolutely every single one of us and our children. And if we're not getting optimal sleep, nothing else is going to fall into place. So it's really, really foundational and vitally important. But anyway, before we start, I just want to go through Professor Dave's bio. Now, if you want to have a bio and cram a lot into a lifetime, this is it. I didn't know where to start with it. But anyway, US citizen, born, educated, trained in England, UK, and between 21 and 2025, an adjunct professor in sleep medicine at Stanford University in the United States. 3 doctorates, not just one, but 3 of them, including doctorate of dental medicine, a PhD in craniofacial cleft palate development, and a 3rd doctorate in orthodontics. And also awarded postgraduate grants, University of Oxford, and later appointed to the Board of Examiners at the Royal College of Surgeons of England. So associated with many universities, including Harvard, published 220 articles in peer-reviewed medical, dental, and orthodontic literature, published 9 books, chapters, contributions, and has over 20 US, Canadian, and European patents. And his startup, one of his companies that he started up, was successfully listed on the NASDAQ. So we're looking at entrepreneurship, we're not looking at science, we're looking at groundbreaking research, and we're looking at everything in between. And his appliance was the DNA. So you're very welcome, Professor Singh. I know our paths have crossed on a few occasions. I didn't always get to talk to you. It was great to have the conversation last night, and all things airway. So I suppose just to make it simple for the general population listening in, when we talk about airway, when we're talking about sleep, what's the most important thing to try and get right when it comes to sleep, and why?
Well, thank you very much for inviting me, Patrick, and you can call me Dave, and that'll make the conversation flow a little bit better. Sleep is central to human health. We spend about a third of our lives sleeping. And so if that component is not optimized, it's not sufficient, then that's going to have consequences on health and longevity. The thing about sleep is you say, well, I slept for 8 hours. Well, you may be in the bed for 8 hours, but did you actually physiologically sleep? And the way we can monitor that is by looking at a sleep study and saying, were you in stage 1, 2, 3? Did you reach REM sleep? And if so, for how long? So a kind of very simple rule of thumb for general people is when you woke up in the morning, could you remember your last dream? And if you did, the chances are you probably had a really good night's sleep. The other question is, when you wake up in the morning, where was your tongue? Was it actually on your palate or was it somewhere else? If it was on the palate, the chances are you were nasal breathing and probably had a good, night's rest that way. So those simple kinds of things can help you just get an idea of where you're at from a sleep point of view.
And do people question it? Are people self-aware of how they sleep? Or do you feel that sometimes do they often put the connections together or the association together? Say, for example, children with poor sleep and how it affects them versus women with poor sleep, how women sleep differently to men. I'm just often wondering about the awareness of it because I know I had trouble sleeping for about 20 years and I had obstructive sleep apnea, which was never diagnosed. And a lot of people I think are in the same boat.
Well, I think you're so right there, Patrick, because there's a lack of awareness, lack of education and information about, sleep. And so some people feel that, well, that must be their normal way of doing things, being drowsy during the day, not having refreshing sleep, maybe having chronic pain, all that kind of stuff. You might think it's a normal, lifestyle for some people. Then you come to a group of people where there's no observer. It could be the bed partner or it could be a parent. So let's take the bed partner, for example, where you're saying, hey, you were sleeping last night, but you were snoring. or you were restless. And so you start getting awareness about the idea that maybe I don't sleep as well as I should. For a young child, parents might notice that the child is bedwetting. And, that happens for a certain stage, but it should not be going on to, mid childhood. For a child, they should be sleeping silently, friction free, and the bed should be dry. So if this child is grinding their teeth at night, bedwetting at a kind of later age, and then, making sounds whilst they're sleeping, well, that shows you that they may have sleep issues, which as a child they may not report. So that's the way you would kind of assess, generally speaking, the quality of your sleep.
And in terms of then, if we were to isolate it then to particular parts in the body, what part of the body is most central when it comes to sleep?
Well, you got the vital organs, obviously. And so when you think
Hmm.
about the heart and the brain, in fact, every system of the body needs to be nourished whilst you're awake and whilst you're asleep. And in fact, we do have, primitive reflexes to guard against that. And this is an evolutionary history type of thing. And so, for example, if you put a baby into a bath of water or into a swimming pool, they will have the dive reflex and stop breathing, immediately. Now, other people, and this is ongoing research, we have other things like the trigeminal cardiac reflex. And what that means is if you're going to grind or clench your teeth, the idea there is that should divert blood to your brain and make sure that you are, in a position to look after yourself. Maybe that is one of the kind of primitive reflexes associated with why people might brux and grind or clench their teeth at night when they sleep. So all the systems of the body can be affected. You can have things like blood pressure, hypertension, strokes, cardiovascular problems, dementia. So many of these chronic illnesses are related to abnormal sleep. And remember that sleep is a physiological process. And so airway is part of it, breathing is part of it, and the sleep physiology is actually part of it as well. So it's a pretty complex kind of topic to really grasp completely. And each of those areas, we can say we have a degree of expertise to say how can we improve that for a particular individual.
And a phrase in terms of when you bring in airway as well, you're talking about the upper airway. You described it, I came across as a living system rather than a pipe. A lot of people would think of the upper airway, they'll think of a throat. They don't think of it during wakefulness, of course, because it's not collapsing. So what do you mean then by that? Like, how is it? It's not just a pipe, but it's a living system.
So the phrase that I have coined is called upper airway homeostasis. So really what I'm saying is the airway is in a system of balance or equilibrium. And that's very similar, identical to other organs and systems in the body. So for example, think about blood pressure. If you're sitting down, you've got relatively low blood pressure. When you stand up, you increase the blood pressure to make sure you get enough perfusion of the brain. So there's a control system, a homeostatic system to say, I need to be able to adapt my blood pressure to be able to function in these different circumstances. Let's take another example, your blood glucose level. It's monitored, it's kept under certain kind of boundaries. It goes too high, too low. You might be hypoglycemic, not enough blood sugar, hyperglycemic. You've got conditions like diabetes where the whole system has gone out of control. So the airway is kind of similar. There's a system of checks and balances saying, how does my airway behave during the daytime? How does it behave during the nighttime? And what's my control mechanism to keep monitoring that, to keep it in balance? And that is what I mean by homeostasis.
And we can influence it, or how does it go wrong? Is that too much of a deep ask? So if it's out of balance, then how has that happened, and what are the factors that are associated or contributing to it?
Well, there's a lot of factors, and it's sometimes multifactorial. There's more than one factor at play. There's an overlap there. So, for example, we take the so-called endotypes of sleep apnea. In other words, you go to the doctor, you have a sleep study done, and it comes back saying you have sleep apnea. What you don't know from that sleep study alone is what's the underlying cause or causes. For example, are you one of those cases where, the jaws are relatively small and set back? which means that the tongue collapses back on itself onto the airway during sleep, and that's causing upper airway collapse. So that's one example. Another example would be whereby you've got a patient who is heavy set, obese, a high BMI. And so when they actually lie down and go to sleep, the fat which is in the abdomen, in the tummy, is being pushed up into the chest area. And what's happening is the volume of the lungs actually decreasing because of that. And therefore, the airflow, air pressure system in the airway is going to be compromised and increased likelihood of collapsing. So those are just two examples of how the airway can be disrupted and the factors involved. And there may be an overlap, as I said. You may have a bit of both or even something else. There could be a neurologic component where, the brain actually is not asleep or the control mechanism for monitoring the airway is deficient or dysfunctional. So there's a little bit of an overlap there. And then you have to think about, how you would diagnose that and then make a treatment plan that's relevant for that particular individual. So we just take it one step at a time.
So even though the crux of it with sleep disorder breathing, it does refer to the pipe. And when we're thinking about the pipe in very simple terms, we're thinking about the throat, we're thinking about the space at the back of the mouth where it meets the throat, and also the nose at the back of the nose where it meets the throat. So
Right.
this section is collapsible, but
Yes.
we want it to stay open. And it's not a good sign if it collapses. And what you're saying is that there's a number of different mechanisms that can be contributing to the increased collapse of the airway.
Correct. And in addition to that, you've got the internal controls or the internal upper airway behavior. So when you think about this pipe, it's not a inanimate object which is going to just be there like a tube. No, it's got its own physiologic behavior. And so what happens there is that, if you want to open the airway, you could open it from side to side, make it kind of wider. You could open it from back to front by pushing the tongue forwards, or you could have a circular pattern like a sphincter where it constricts and then dilates, opens and closes that way. So what we know is that the human upper airway has all of those three types of behavior, and we can check that by using an endoscope, put it down the nose, look at the back of the throat, and then actually pull the jaw forwards, pull the tongue forwards, and say, how did that airway actually open? What was its actual behavior? Now, the whole idea here is to actually mimic that behavior and not replace it if at all possible. So, for example, if the airway is collapsing on itself, one of the treatment that people do is, continuous positive airway pressure, CPAP. And basically you're blowing air down the pipe and making sure that it doesn't collapse in on itself. Just like blowing up a balloon, it just kind of, dilates. Now, what's happening there is you're kind of overriding the body's own system because you monitor the kind of, aperture of the airway using mechanoreceptors and other receptors. The muscle that goes around the airway is being monitored. It's like almost like any other muscle. Now, this is kind of unusual because at nighttime, your muscles actually relax. And when they relax, you have an increased likelihood of airway collapse. So you have to think about how is this airway behaving during the day versus during the night. And so, the idea is to strengthen the airway or give it some kind of support system so it doesn't collapse whilst you're sleeping at night. For example, you could put an oral device, like a mandibular advancement device, into your mouth, hold the jaw forwards, and prevent the airway from collapsing. Different ways to maintain that airway patency based on the behavior of the airway itself as far as possible.
So there's two aspects of it in terms of, because I was reading your paper as well, your review paper 2025, and you did bring in craniofacial abnormalities that can be present. You did talk about having the mouth closed and being able to breathe in and out through the nose. And just a while back, you talked about obesity and how, for example, it reduces lung volume, and all of those are feeding in. And I'm always curious from a breathing perspective, but I'm sure we'll come back to that. So,
Mm,
upper airway behavior,
yes.
that it's a behavior rather than a structure. And how is this then, like the tongue you've mentioned a few times, and you talked about the tongue being having to rest. So we should be waking up with the tongue resting in the roof of the mouth. Is that trainable? Is it normal for people to have their tongue resting in the roof of the mouth? Is it something that people have to be observant of? If you have your tongue resting in the roof of the mouth during the day, will it genuinely translate into correct tongue resting posture during sleep?
Well, that's a very key question, Patrick. When you think about upper airway behavior, we've got to think both of the structure of the airway and then how that behaves, how it actually executes the functions of staying open. Now, let's take a child, for example. They've got a smaller airway than an adult, generally speaking. But generally speaking, a healthy child does not have sleep apnea. Why is it that they have a smaller airway and don't have sleep issues, whereas an adult with the same size small airway does have sleep apnea? Well, the answer there is the muscle tone. In the case of the child, there's sufficient tone in the muscle to prevent it from collapsing. It can withstand the external pressure. In the case of the adult, there's a lack of muscle tone, and therefore, it's more likely to collapse. So, well, how does the tongue play into that? Well, it goes to the very beginning of life. And so when a baby is born, humans by definition are mammals. And therefore mammals are classified because they are going to be breastfeeding, nursing, suckling at birth. And for that procedure or for that mechanism, the tongue has to be very kind of proactive and functional, and the baby can breathe through the nose and swallow, at the same time because of that tongue action. Now, what's happened over centuries is that we've kind of moved a little bit away from that mode of feeding. And so a lot of kids are not actually breastfed for a prolonged amount of time. And you kind of augment that with bottle feeding and with pacifier use. Now, when the feeding bottle, the milk bottle goes into the baby's mouth, it's a different positioning because the tongue is actually depressed as opposed to touching the roof of the mouth. And so it's a different feeding mechanism. And this kid is going to be swallowing large volumes of fluids. And classically, after you bottle fed a baby, you put them on the shoulder, you tap their back, and they'll have a big burp because they're actually swallowing air at the same time. With the use of a pacifier or a dummy, what happens is that the tongue is displaced downwards. And now you're training the tongue to take up this unusual position because this pacifier is in position, it takes up the space that the tongue would normally take. Now we go a bit further and look underneath the tongue, and we find out, it's kind of attached to the floor of the mouth using a frenum. And so there may be a degree of tongue tie, which needs to be looked at to say, can this baby easily breastfeed or not? Or can this be able to easily kind of be fed or not? If they can't, that may be an idea or indication to say maybe they need a tongue release. This is where, as a child gets older, we start building in things like oral myofunctional therapy to actually train the tongue to sit on the palate. And that is a very kind of important positioning to achieve. Now, we can mimic that behavior using some devices. So we did a study whereby we looked at the position of the tongue making the S sound, as in special 66, 67, 68, and then we measured the airway size in that position. So we measured it in that position, and then we measured it just in the normal, regular position, and we compared the two. And what we found is when you have the tongue making this S sound, you actually are going to stretch the airway a little bit. It kind of opens up and actually increases the functional residual capacity, which is the actual volume of air in your lungs, which you need to prevent airway collapse. So it's not as if the tongue is working in isolation. All of these components are actually connected. And it's our job to connect the diaphragm with the lungs, with the trachea, with the pharynx, to the tongue. All of that system, the nasal airway, all of it needs to be connected. Say, how is this system set up for success? And surprisingly, we get the clues from, clinical observation, from development, embryology, and also from evolution. That's a pretty complex picture, but when you put it together, it seems to paint a very nice, kind of idea in terms of what is good for survivability and longevity for humans.
So, if you had a wish and you were able to cast it in terms of sleep medicine, where would you see the future? And I'm only talking about oftentimes I feel as an onlooker in. I have an interest in sleep, of course, with respiration. I don't feel it has been a great success story. I feel there's a massive lack of awareness. There's 85% of people with sleep apnea don't get a diagnosis. Many of them can't tolerate the treatment with the CPAP. There's no talk about correct tongue resting posture. You talked about lung volume, nasal breathing, craniofacial development. It's been overlooked. But you must have something that you would love and you were thinking there's absolutely something in this. Where do you think we really need to be going?
Well, I think you're totally right, Patrick, that the healthcare burden of sleep apnea, both in the US and worldwide, has not even peaked as yet. What the studies are showing is there's probably about 1 billion people worldwide with some form of sleep disordered breathing. And we haven't reached the peak of that. In the next 5 years or so, within the US, we can expect maybe 70 or 80 million new cases. And just think about the healthcare, burden that brings with it, both in terms of cost and morbidity. So where do we start with this? Well, I always start with education and information, increase patient awareness to say, hey, look at this, and prevention is better than cure. And if we can prevent a situation from arising, excellent. If you can capture it early, great. But at least if it's been diagnosed at a later point, let's have some treatment options as well. So really, it's a very broad ranging strategy from childhood through to young adults, through to older people to say, what is your risk of, some kind of airway, breathing or sleep issue? And part of that overlap also is genetic. Because when you think about it, there are approximately, I'm going to say 67 known sleep issues or sleep disorders. And one of those is sleep apnea. And it's probably the most common, but it also overlaps very strongly with insomnia. And so you may have both. You may have insomnia, which is like a neurologic kind of condition where your brain is not allowing you to sleep for whatever reason. And on top of that, or separately, you may have sleep apnea caused by some kind of airway obstruction. And co-MISA is when you have both. So we have to look at this from a patient point of view, start with education information, and patient awareness is increasing because now we have more of the wearable technology, wearable devices, the tracking devices, your smartwatch, your rings, and stuff that you can wear, which gives you an idea of how good am I sleeping? And then you get an idea of how close you are to the normal range and if you really need to get some kind of intervention. So that's a place where you could start.
So it's very complex, and that makes it tricky though as well. It's very, very intriguing. And I'm sure as well you've looked into the whole aspect of, say, women and how they're sleeping differently to men.
Yes.
Very often it's been said that the sleep industry has evolved very much around men because men, when we stop breathing, we can be snoring heavily and then there's total silence. And of course, the partner is lying awake, wondering what on earth's going on here. But with
Yes.
women, it's quite subtle. I'd really like you to talk about that one, the subtlety of breathing in women in sleep and how that can then have an impact as well for females and how it differs from men.
Sure. So part of that healthcare burden, which is on the horizon, will be disproportionately representing women who have been underdiagnosed or non-diagnosed or just were flying underneath the radar. So the classic example, as you said, is a middle-aged overweight guy who is snoring. It's kind of the classic, of, sleep apnea. However, it could be quite the reverse. It could be a younger, non-obese woman who has kind of undiagnosed airway and sleep and breathing issues. The classic one there is upper airway resistance syndrome, where they do a sleep study, but it comes back negative, saying you don't have to have sleep apnea. And the lady is saying, well, I don't sleep well, I don't feel refreshed. There may be a history of chronic pain, for example, headaches. It could be TMJ pain, it could be shoulder pain, it could be, backache. So there's chronic pain there. And these are non-obese people. So the idea is what happens is that you have to think about all the different aspects of sleep and sleep architecture. And one of those is arousal. And some people have a high arousal threshold and some people have a low arousal threshold. In other words, there's a big thunderstorm going outside and you sleep all the way through it as if nothing happened. And the other person, a pin drops and they suddenly wake up and they're aroused. Okay. So That is when we have to think about, the respiratory effort related arousal, RERA. Now, what happens is that there is a respiratory event. So this patient is sleeping and the airflow is being decreased, or they haven't quite got to apnea, but the airflow is being decreased and they become aware that they're becoming hypoxic. They might not even reach that stage, but the kind of reflexes kick in and they wake up out of sleep. They may clench or grind at that point, and then they fall back asleep. And they do that several times during the night routinely. And that is called sleep fragmentation. They're momentarily waking up and getting back to sleep all the way through the night. And so when you do the actual sleep study, there's no apnea to really report because they didn't reach the point where they actually stopped breathing. They actually woke up, took a little breath, went back to sleep. But it kind of ruins the sleep architecture. It's fragmented sleep. So when you wake up in the morning, you might have a headache and you don't feel refreshed and you can't explain why. And as I said, there may be some bruxing, grinding, or clenching going on there as well. Now, that condition, upper airway resistance syndrome, can actually be mild, moderate, and severe. So it's a bit of a grayscale. We haven't quite got it down to a fine art as yet, but we're working on it. When you think about the severe form of upper airway resistance syndrome, it's not sleep apnea. It's going in a different direction. And those patients may present at the clinic with a diagnosis of fibromyalgia, chronic fatigue syndrome, those types of kind of examples where you can't quite put your finger on what's going wrong here, but a detailed sleep study and a sleep questionnaire may help in terms of getting to clinch the diagnosis.
Yeah, it's really so tying it in then with I can feel a sense of frustration with females if they go, for example, and do a sleep study. I'm not sure if every sleep study actually identifies or investigates RERAs,
Mm,
respiratory effort related arousals. And the other connection here is so we're talking about, say, just moving on to chronic fatigue syndrome, fibromyalgia. These people are exhausted, but
mm,
yet they feel that they're too wired to fall asleep. So it often sounds like a contradiction. If you're exhausted, you feel that you would drop off at the flick of a switch,
right.
but the nervous system doesn't allow that to happen. Is that
Correct.
maybe because what's happening during sleep carries into the day, or in terms of the nervous system, what's happening during the day is carrying on to sleep? Is it bidirectional? What's your take on that?
No, absolutely. You're absolutely correct, Patrick. So what happens during the night flows into the day, and what happens during the day flows into the night. So let's give a kind of rule of thumb, just, a very general idea. I mean, this hasn't been fully researched or published, but generally speaking, if you have, a younger non-obese woman who comes to the clinic saying, I don't have, refreshing sleep, I kind of start a conversation by shaking their hand. And actually what I'm doing is palpating their fingertips to find out, are the fingertips cold? And then I ask the question, do you have cold fingertips and toes? And, sometimes they say yes, and sometimes they say no. So the question is, why would you have cold fingers or cold hands during the day? And one of the ideas is that when you sleep, you conserve energy. And so when you're sleeping, your core body temperature goes down, your heart rate goes down, your rate of breathing, respiration goes down. Everything is in a state of, let me conserve energy. But if you were working during the night because of arousals, then you're going to conserve the energy during the day. And one of the ways you might do that is peripheral vasoconstriction. So now you've got kind of cold fingers and cold hands. It's an idea that needs a bit more kind of research on that. So the body is going to use its reflexes to try to promote longevity and make sure you have a long and healthy life. Okay. One of the things that happens is melatonin release. Melatonin is an alarm clock. Now, the way we use an alarm clock is when we're sleeping, the alarm clock goes off, we hit the snooze button, and then we sleep for 10 more minutes, and then we wake up. Now, melatonin is the opposite. But what it does, the alarm goes off, early evening to say, start getting ready for bedtime. But what do? We watch the TV, we work on the computer, we have our devices, we have our cell phones, all that blue light. suppressing melatonin, and we have actually hit the snooze button and said, I'm not going to go to sleep, even though my body is saying it's time to go to sleep. So we can do a few little hacks here to say, okay, I'm going to look at sleep hygiene. And sleep hygiene is saying, what is the kind of protocol or the things that I do to allow me to get a good night's sleep? I want to have a meal a little bit earlier. I don't want to have a heavy meal at nighttime. I don't want to have bright lights, especially blue light shining into my eyes in the evening. I want to slow things down. I want to get my breathing under control, maybe some relaxation, whatever works for you, meditation, yoga, whatever works for you to get you to the point where you're relaxed and ready to sleep. And then the bedroom itself, when you think about it, because of mammals, we want to actually try to mimic a form of hibernation. So think about, bears that hibernate. You have a good meal, just prolonged over a few months of course, a big meal, they're kind of slightly overweight. They find a den which is very dark, it's kind of cold, and they go and sleep in that den. And when they sleep in the den, the body temperature, the core temperature goes down. They get peripheral vasodilation and keep snug inside of the den. And so we are trying to mimic that ourselves when we sleep at night. So a dark room, slightly cooler, okay? And then we're going to allow our bodies to produce that physiological state of sleep. So, especially for children, is to build a routine. And so they know that at this time it's bedtime and that's it. There's no threshold, there's no kind of, negotiation there. It's a full stop. You go, it's bedtime, we're done. The younger the child, once you get that kind of idea going, their body will respond and they will sleep. Again, depends what happened during the day. Were they eating junk food? Were they having sodas? Were they having snacks? And what we know from research is the kids who have these junk food items have less healthy sleep. We also know that children have different sleep times compared to adults. So, for example, teenagers, they like to go to bed later and wake up later, and if you allow them to do that, their grades in school, generally speaking, improve. So this is the whole idea of sleep hygiene in terms of what is appropriate for which individual. Older people tend to go to bed earlier, sleep longer, and wake up earlier. And so when you think about it, in the human family, some individual is awake or partially awake during a 24-hour period of time, which may have been a protective response when we were living on the savannah and so on and so forth. So these are all ideas in terms of the broad picture of why sleep is so central for human health.
And really, what you're saying in essence is that if the brain interprets there's any sort of threat or danger, reading it as being overstimulation, whether it's by diet or lights or content or social media or anything else, well, the brain is not going to let the body fall asleep. So, whatever we
Correct.
do, we need to be telling the brain that we are absolutely safe.
Correct. And again, sleep is a physiological event, it's a process. And so there are certain requirements. Just the way a bodybuilder says, I want to be, have a good dose of protein and sufficient carb to be able to a really good workout. The brain itself needs nutrients to be able to have produce good nighttime sleep. So it's worth looking at the diet from an organic point of view, saying, am I deficient in any of those components? And if there's no deficiencies, you don't need a supplement. But if you do identify deficiencies, then you can say, maybe I need to add vitamin D or B12, vitamin B12 complex, something like that, to say, allow my brain to produce a physiology to allow me to sleep. And this is where, detailed testing can come in to say, if you can't figure out why a person can't sleep, you got to look at the metabolic component to say what's going on the metabolic side of things, which is not allowing this person to sleep. Or is it a neurologic thing? Part of that may be genetic. So, it's a complex, kind of story, but experience is a great teacher. When you're talking to an individual or a patient, you go through the history and you find out what are the clues that I'm picking up in terms of what's needed in this particular case and how can I help this individual?
You've done some research looking at how some devices, so one, for example, the didgeridoo from Australia, and a similar device, and you were intrigued with what by playing that device, the didgeridoo, with circular breathing, that you found that it was able to have some positive impact on sleep. So are we saying Aborigines, they don't get sleep apnea? I'll
Yeah.
pass that to you.
Well, that's really, I mean, when you look at anthropology, human anthropology and culture, it's a fascinating subject. I could make it my second profession if I had the chance. But think about people and cultures. Take the Aborigines from Australia, for example, and they are playing the didgeridoo, which is this very long kind of pipe, and it makes a kind of drone. It's a very kind of specific type of frequency that comes out of this instrument. And then you think about people from Asia, Polynesia that have the conch shell. And when they play that, they also have a positive impact on sleep apnea. So these two have something in common in terms of what is allowing the body to decrease the severity of sleep apnea. So what these are really wind instruments. And if you look at other kind of reed instruments or, wind instruments, they don't have a similar effect. It's these two really have a big impact. So part of it may be the whole vibrational response that you get when you're playing these instruments. And that may be a signal that's going down right down to the mechanoreceptors of the airway saying, hey, I need to wake up and do something. So, you're thinking, hey, what is a mechanoreceptor? I don't know what that is. Well, a simple analogy is when you walk into the lobby of a hotel, you're walking in and the doors open automatically. And the reason is you're actually standing on the pressure sensors, which are in the floor. And when you stand on those pressure sensors, the doors open. Now, if those pressure sensors were not working, the doors would stay shut and you can't get in. So similarly, within the airway, there are these pressure sensors. We'll call them mechanoreceptors. And so when they are stimulated, the airway is going to open. And so my idea is to say, okay, we can work with these, mechanoreceptors to sort of open the airway. So then what I did was I took the signal from the, didgeridoo and the conch, and you capture that signal digitally, and then you place that signal into a wearable device. And then we're going to test that device to say, does it have an effect on sleep apnea? So we've got a lot of research to do before we get there, but that's a research question. And that's what I'm looking at currently. Now, you might not have the didgeridoo or the conch shell in Ireland or in Europe or whatever, but what you guys do have is bagpipes. So what I'm thinking now
Mm.
is the drone from the bagpipes, does it have a similar effect to the conch and the didgeridoo? And so if someone wants to do a PhD, let me know, because that would be a great study to do in Ireland or Scotland or one of those kind of places. It would just be fascinating to find out, did we get the hypothesis, the basis for it? Did we get it right? Or are we in the close to it? Or, what is the situation there? So a lot of work to do, but it's a lot of fun also.
Yeah, it's almost that you're implying that these civilizations, that part of the playing of the didgeridoo wasn't just for the sound itself, but there was also, they knew that there was some connection, maybe not so direct, but they knew that it had some effect in terms of possible sleep or airway. Or do you think
Correct.
that's plausible? Do you think it was just by chance? No, it's actually, yeah.
I think that, the body does not lie. And so if you're doing something which is detrimental to the body over a long period of time, it doesn't last in society, it fades away. But something that's done culturally, which is beneficial to the body, you tend to keep it and maybe enhance it and then becomes, iconic and in some cases. Let's take the opposite now. Let's go
Okay.
to Japan. And Japan has got the big sumo wrestlers, and these guys are heavy. And if you know a little bit about the sumo tradition is, they have a very specific training pathway. They are athletes. One of their major things to do is to be heavy so they can outweigh their opponent. Now, how do they put on that weight? Well, obviously they eat a lot, but also very significantly, they sleep a lot. After having a big meal, they have to sleep. And of course, during that sleep, they may have sleep apnea because they're heavy. So if you look at these athletes when they're 20, 30 years old, they are big, heavy guys. But when they are 50, 60 years old, they actually lose that weight and come back to a normal BMI as far as possible. So when you look at some of these athletes, they're not recognizable when they're 60 or 70 compared to when they're 20, 30, because it's a very nice cultural routine that they have. It's a discipline that they follow to make sure that they're doing these things. But the point here is that they're heavy, they get sleep apnea, and then it goes away. So that's kind of, again, we need to look at that a bit more detail, but that's a cultural phenomenon just to think about in terms of how we think about body weight and breathing and sleep.
It's almost the opposite to some of our athletes. They're slim when they're in their early 20s and 30s, and then she's in midlife crisis hits. And
Right.
the other thing about obstructive sleep apnea, it's very challenging to lose weight when one is sleep deprived because it can affect food.
Yes. And again, this is again what happens during sleep. Well, our hormones during the day are working differently compared to at night. So classically in deep sleep, you get a peak of growth hormone. So if your mom told you you grew when you were asleep whilst you're sleeping, totally true. So the growth hormone is secreted in stage 3 sleep, but it's a metabolic hormone. It's the antithesis in a certain extent to cortisol. So cortisol or cortisone, what's happening is that it's an anabolic steroid. So if you're not asleep and you're stressed out and your cortisone is going to peak, it's going to wake you up because it's a bit of a stress hormone, but also because it's anabolic, you're going to put on weight whilst you sleep. The reverse is that when you are sleeping, you get growth hormone peaking, and therefore you actually lose weight when you're asleep if you are overweight, or if you are growing, you use that growth hormone to deposit bone, muscle mass, so on and so forth. So you have to think about the hormonal balances. Again, these vary during life. And so, the idea is to maximize that, optimize it for human health.
Should clinicians be thinking differently about treating obstructive sleep apnea in light of homeostasis?
Well, I think it's kind of interesting because new technology is being produced all the time. The classic mainstay has been CPAP, which is continuous positive airway pressure. But now we are just introducing intermittent CPAP. So the pressure is not continuous, or at least it's not high continuously. So when you breathe out the end tidal volume, your airway is most hypotonic and most likely to collapse is when at the end of the breath. And so the machine, the CPAP machine, will actually apply the pressure at that time as opposed to any other time of the respiratory cycle. So that's a kind of nuance which is going to help people to tolerate CPAP slightly better. However, it doesn't get away from the fact that you got to wear this machine when you sleep at night, which a lot of people might not find, comfortable. Then you have to think about the new ideas in terms of, okay, I'll use something like, hypoglossal nerve stimulation. So these are the implanted electrodes. And so what they're doing is when the airway starts to collapse and you become hypoxic, you get an electrical signal goes to the tongue, to the hypoglossal nerve, and actually pushes the tongue forwards. Now, if your airway opens front to back, that's great. But if your airway opens side to side, or the circular pattern that I mentioned earlier, it may not be as good. So in those cases, you think about a different mode of stimulation. It's still electrical, it's still surgical, called the ansa cervicalis stimulation. And now what we're doing is trying to elongate the muscles of the neck, and when you do that, you get a response called caudal traction, which elongates the airway. And when you do that, the airway the walls of the airway stiffen a little bit, and that allows the airway to open and prevent it from collapsing. So both of those are surgical kind of interventions. They're expensive, it's invasive, and not everyone's kind of option or choice. And then you think about what's downstream from there. So the new idea is the GLP-1, the glucagon-like peptides, and the GIP. So what we have here is the weight loss drugs. And so what's going to happen is trying to lose the weight. It takes about a year or so for the drug therapy to have a really good effect on sleep apnea, but they do work in that respect. So it's just an up and coming kind of technology. The thing about drug therapy, as you know, pharmaceuticals, is that there can be side effects and they can be expensive. So again, you have to think about, I can take this, pill for my sleep apnea, but if you stop taking the pill, there can be rebound and regaining of weight, or you can have issues, with the airway there as well. So all of these ideas are under development as we speak. So, we haven't reached the peak of sleep apnea, in the US or even worldwide. So a lot of work still to be done.
Okay. And I'm curious, I'm going to ask you this question. What's your take on breathing retraining? And say, for example, the importance of educating clients to breathe in and out through the nose with correct tongue resting posture with better movement of the diaphragm, but also improving their breathing from a biochemical point of view so they're less susceptible to, say, for example, high loop gain, which will be unstable breathing.
Hmm.
What's your take? Do you think that my role is going to fit into the mainstream? Because this is where we would love to see. I think you've talked about an integrative approach. It's even in the title of your paper here. So it's almost
Yeah.
that I'm putting you on the spot. So I have to be selfish here and think about where's breathing in all this.
Well, as I said, airway, breathing, and sleep is a continuum. You actually can't isolate one without affecting the other two. And so if you say to me, where does rebreathing come into the equation? My response is it plays a central role. Now, why is that? Well, the idea, as I mentioned at the very beginning, is to mimic the body's behavior. Biomimicry, biomimetics. Let's not reinvent the wheel. We already have the structure that we need to perform the function that it is actually designed for. But there may be dysfunction and there may be spatial misalignment, so on and so forth. But it's like saying, well, I'm overweight and I have high blood pressure and I can't sleep. One of the things you could do is saying, I'm going to go to the gym and get my little workout routine going. So now I'm working out on a regular basis. And now that allows me to increase my muscle mass, increase my bone mass. I may lose weight, but my blood pressure will go down. And the chances are I will sleep a little bit better. When it comes to breathing, you have the structures available there, but they're not being utilized or they're being utilized in a non appropriate way. What do I mean by that? Example would be hyperventilation. If you look at our modern population, generally speaking, my impression is we hyperventilate. We're under a lot of stress. We have a very stressful, fast paced life, and we tend to hyperventilate. What we are, quote, designed to do is go for long walks on the savannah. And then we have periods of intense activity where you're going to, say, proactively go hunting, something like that, or you're going to be, taking time out and then being in the sympathetic mode where you're eating, digesting, sleeping. But our lifestyle has changed dramatically, but our human genes have not changed for the last 30,000 years. Is the human genome. So the breathing part comes in because we can retrain the system and reset the system. So then we are breathing approximately there's 4 to 6 breaths per minute, slow it down and using the lung volume, getting the diaphragm to do its job and then be able to breathe in and out through the nose. And the fact that we are nasal breathers is important for, the inflammatory responses that are inside the body. So when we breathe inside the nose, what happens is that we're actually storing nitric oxide in the sinuses, the maxillary air sinus, in your top jaw here. It's a place where you produce and store nitric oxide. So when you are breathing through the nose, when the air rushes past the ostia or the opening of the sinus, it picks up the nitric oxide and then delivers it down to the distal parts of the airway. And that nitric oxide is a muscle relaxant. It's going to open up the smooth muscles, allow good oxygen exchange when you get down to the pulmonary alveoli. So rebreathing is not to be taken for granted. We can all breathe, but it's like walking, running, anything else. We can retrain ourselves to breathe most optimally. And again, from a cultural point of view, this has been done for centuries. Practices like yoga, where they do, specific types of breathing. And so, yes, in the modern world, breathing is central for human health. And there's no reason why retraining breathing can't be done for a broad range of people.
Excellent. Well, I say here's to that. Um, you have an event coming up. Will you talk about it? Because there will be healthcare professionals, quite a few dentists. They go down the route of breathing training. We have functional therapists. So, your event, who is it for? What will they expect? And the dates of it as well, please.
Yeah, so this is going to be in London, UK, on May the 1st and 2nd of this year. And the title of the presentation is Craniofacial Sleep Medicine, really head and neck in terms of the focus. So doctors, dentists, orthodontists, allied health professionals, oral myofunctional therapists, respiratory therapists, all of those kinds of people. It's a kind of broad audience that I'm going to address. And I really want to look at, airway structure, airway behavior, how that interfaces with breathing, how that interfaces with sleep, and then provide a very simple technique that can be used clinically, like a device that can be used clinically to help people along that pathway if they so choose. So it's really continuing education. Is to try to bring some of the thinking up to date in terms of what we found so far and to share it with, a European audience. I haven't spoken in Europe for a while. So this is a nice way to kind of break the ice again and get the conversation going.
Absolutely. And given the complexity as well, an integrative approach is very necessary for progress to happen. So, future research. Um, what do we still not understand? Or this might be a tricky question about the upper airway control that frustrates you the most. Is there something that been trying to get your head around that
It's,
what would
yeah,
you feel is the most challenging thing?
well, I think you got to look at it from different points of view. And so, are you looking at it from a healthcare point of view? One of the things in the US and in fact worldwide is healthcare disparity. In other words, some people have access to excellent healthcare and some people don't. And so we want to try to level the playing field saying, do you have access to healthcare? And, all right, so now you do. But in that system, do you have availability of the things that you need in your case? Whether it's rebreathing, retraining the breathing, whether it's a CPAP machine, whether it's surgery, whatever it happens to be. And then part of that is it affordable? If you have to pay out of pocket or you have to, cover by insurance or you've got a health insurance, is it affordable for the society, the country, the nation from a global point of view? So one of the things to think about is healthcare disparity because sleep issues are worldwide, they're global, and we want to be able to address a wide range of people rather than a smaller select group. That's kind of part of the thinking there in terms of where we're going with it. The thing that's going to help us is technology. For example, there was a time when you had to go to a hospital or a clinic, spend the whole night there to get a sleep study done, which was expensive and not very convenient. But now what we can do is telehealth. We can do remote, teleconferences. So the physician or the clinical, care provider can be working with an individual remotely, just like we're doing now, and being able to help them with their healthcare, requirements and needs and concerns, and cut down the cost. So part of it is the technology, and then the technology expands then onto wearable technology. So if I can do a diagnosis with a device that you wore at home, can I do the therapy at home as well with whatever is the most appropriate therapeutic option? So several areas to under research in terms of where we're at. So I would say it starts with the re-education or education and information and the awareness to say what is going on here. If anything, are you a candidate that needs some kind of help? If that's the case, we can do some tracking, some pre-screening, some screening, and that brings you into diagnostics. To say let's do a formal kind of workup to say do you have sleep apnea or not, and then from there you have to think about what is the most appropriate treatment. And that may be an integrative approach. So there is a combination therapy. So, there may be, a respiratory therapist, there may be a physician, whoever is involved in making sure the patient gets what they need. And then the final part of that, of course, is, the financial burden in terms of the healthcare requirement, the compensation, how was this drug or intervention paid for? So several areas that need to be touched to say, how do we get a working solution, which is comprehensive? Not an easy thing to do, but you keep chipping away at this kind of individual bits, and eventually the tide will turn. So that I think we're at the start of something, huge. It will take a generation to get our heads really around it, but every little single step we take is going in the right direction.
Absolutely. And given your statistic that you talked about at the first, that's 936 million or almost 1 billion people that are estimated to have sleep disorder breathing on the planet. Like, it's mind boggling. And
Co-
definitely
Mm,
it's crying out for a solution and an
right.
integrative approach. So, final
Yes.
words, Professor Singh. I really enjoyed the conversation. Um, you know, whether it's a professional or whether it's a lay person, what would you like to close with?
Well, I think that you're doing a great job, Patrick, of getting people on board on the common platform, open communication. It's not as if we have to stay in silos. It has to be an integrative approach.
Mm,
We have to think from childhood and what happens before the child is born. I'm talking about the health of, the women of childbearing age. So if those women are healthy, they have healthy babies. And what happens in that postnatal time is critical because what we have changed is our child rearing practices. The kids are being, brought up differently. They spend a lot of time on devices. It's a very different kind of environment that we were actually kind of evolved into, and there's a lot of things going.
mm.
So the challenge is to meet those adaptations, those changes, and stay with the game. Prevention is better than cure. Early diagnosis, okay, and then therapeutic options, which are easy for the individual, not expensive, and not very intrusive. Those would be the kind of thing to say, okay, here's what I'm looking for as we move forwards.
Your event again, so it's on the 1st of second and 2nd of May. I didn't ask you, how do people find out about it? Do you have a website? Do you have a link? How can people
Yes,
find out more?
yes. So the website would be REMA, that's REMA dash sleep.com, REMA-sleep.com. And that will bring you to the course and the events that we're holding this year. You click on that, and then we'll be able to help you out. So yeah, it's relatively easy to do. So yeah, hopefully we'll see a few more people there.
Yeah, no, absolutely. I think we have a lot of people interested in sleep. It's a big part of what we do. And I liked what you talked about, making it accessible, making it affordable, making it easy, and in your quest for that. A pleasure. I enjoyed the conversation. Professor Singh, I think the listeners going to as well. Root will put everything into the show notes so people will be able to access the link. And thank you very much. Enjoyed the talk.
Thanks, Patrick. Thank you.